Good afternoon from Brighton, and to others, good morning and good evening. Thank you for the introduction, and of course, thank you for asking me to speak today. I'm going to be talking on moving to Mhealth, HIV and future care, using the specific example of the Emerge project, which I've had the privilege of coordinating over the last 5 years. Interest in digital health options in HIV care, HIV prevention, and sexual health has been increasing steadily over recent years, and it's great to see the evidence base for these digital health interventions building. Interest in provision has accelerated rapidly over the last year in the context of COVID-19, out of necessity. As we continue to cope with COVID and as we look to reset and restore our services, we've got a great opportunity to stop, to think and to work through how our services should be co-designed, taking into account digital health. It's really important in clinics and in community settings that our services are and remain person-centred, and that we ensure that we don't leave people behind. These are my declarations of interest. To start with then, some definitions, and whilst many will be very familiar with these terms now, it is perhaps helpful to look briefly and understand their meanings. Telemedicine refers to the remote diagnosis and treatment of patients by means of telecommunications technology. Mhealth, a subtype of eHealth, specifically refers to the use of mobile wireless technologies, i.e. mobile phones or devices, and increasingly to wearables. Out of necessity, much of the move to telemedicine in clinics during the pandemic has been a move to telephone consultations, with a telephone call taking the place of a face-to-face visit. In some settings, video consultation functionality has given another alternative. This works well for some people in some settings, but with IT literacy, access to stable internet being an issue, with data and with appropriate privacy at home, this may be less easy for some than others, including for some clinicians. In community services, the same. Appointments, groups, peer support have moved online, with innovative approaches being used to keep in touch and to support people who access these services. Much has developed locally, others at a national or regional level, and it would be great to hear some of your experiences of these if there is time in the discussion. In Europe, EATG have published a series of rapid response papers looking at the provision of services, including digital health, with a paper on eHealth coming shortly. It's really important to emphasise, as we all know well, that it isn't just about the tech, far from it. It's about people, about pathways of care, and about context. Digital health is very much going to be part of our offer going forward, but it can't just be plugged in. While we are here, I'd just like to mention the WHO Global Strategy on Digital Health paper that has come out recently, as well as the paper from the European Commission, both looking to empower citizens to promote healthier lives in a healthier society and using a person-centred approach as we look towards digital health in the future. Just briefly for context as well, though, we know that just fewer than 60% of the world's population have access to the internet, and that this isn't always stable. This varies from 24–25% in some areas up to 96%. Mobile phone access is slightly better at 60–66%, including all phones. Smartphone sits at around 50%, but that still means that there's around 2.6 billion people without access to our phone. As I've mentioned, our challenge is to reset services, taking advantages of all the advances in digital health to empower individuals, to help manage capacity in clinics, but also we must ensure that our services remain accessible and can support those who need them in a person-centred approach. We do need urgently to address concerns about privacy, security and trust. We need to understand clearly what happens to data and be able to advocate around this. We need to ensure that our populations have access to devices, to data, and to stable internet. If we are to achieve the targets of the UNAIDS 2025 Reducing Inequalities Programme, rather than exacerbating them, and if we are to get to zero HIV transmissions, we need to embrace digital health, but need to go into this with our eyes open. Moving now to talk more about the work that we've been doing within the Emerge project by way of an example of Mhealth. Emerge has been a 5-year Horizon 2020 funded project involving a consortium of 12 partners, including our 5 clinical sites in Antwerp, Barcelona, Brighton, Lisbon, and Zagreb. Within the Emerge project, we have co-designed, implemented, and evaluated an Mhealth supported pathway of care for people living with medically stable HIV. We've had a high level of community involvement throughout the project, led by our project partner, EATG. In the first year of the project, our colleagues in Antwerp led on a detailed background assessment at each site, looking at clinical service provision, IT setup, and medico-legal aspects. And we also in this year started a co-design and socio-technical evaluation, which is run iteratively through the project, led by the University of Brighton and EATG. The concept is quite simple. Individuals are seen once a year face-to-face by their clinician, with the interim 6-month visit carried out using the Mhealth Platform. The Emerge platform consists of a clinical web application that sits within the hospital firewall. This is integrated via an API with the hospital or clinic information system or database. Once data are reviewed by the clinician, they are encrypted and pushed through the cloud to the individual's mobile phone or device. No data is held on the phone and all is GDPR compliant. Our clinics review and send results, appointments, and antiretroviral information through to the person's mobile phone. There's a hyperlink out to the Liverpool Drug Interaction website to check for potential interactions. The app includes frequently asked questions and links to health promotion information as programmed at sites, and it allows for reminders for appointments and medication via the app or saved into your calendar. Each time the clinician reviews the results, they send a message to the patient with the data, so to help interpretation, and notifications can also be sent by the clinic to all users, which has proven very useful for communications during COVID. Within the study, our messaging was one directional, but from user feedback, we have now developed two-way messaging. I should emphasize that whilst the platform can support video consultations, the communication in the study was one-way and asynchronous. The platform was integrated at each site during 2017, demonstrating its adaptability to different IT settings, which varied from a local area network of 3 computers with data initially held on access, through to clinics and more complex hospital information systems. We used the framework of MAST for the overarching evaluation. MAST is an HTA type methodology designed for assessing telemedicine applications that was developed as part of an EU-funded project. Once the preceding factors were met, we invited people attending each of the 5 sites to join the study, and the inclusion criteria are shown here. As well as collecting virological outcomes and visit data, we asked people to complete a questionnaire pack at baseline and then every 12 months. Systematic reviews were carried out to identify appropriate outcome measures for empowerment and health-related quality of life. We were also able to validate the HIV-specific positive outcomes as part of the Emerge study. Health economics analysis was done by Eddie Beck and his team, with micro-costing studies completed at each site. The study was opened sequentially at sites between April and November 2017 and was open to enrolment for 12 to 18 months. In total, 2,251 people enrolled in the study across the 5 sites, representing around 23% of the cohorts. The demographics of the study population were similar to that of the clinic cohorts. Uptake varied by site for a number of reasons, including clinician engagement, where there was change in practice, at the time a lack of virtual tariff, and perceptions of digitalising clinical work. Patient choice, changes to current pathway, no SMART, and concerns about confidentiality. I should say also that technical aspects and research questionnaires also contributed. It's been really interesting over the last year to see how some of these barriers have been overcome during the times of COVID, particularly relating to reimbursement of virtual appointments and those aspects. We did have withdrawals from the study at each of the sites during follow-up, reflecting individual choice and clinician recommendations, with 3.6% withdrawing in the first 12 months and 3.8% between months 12 and 30. The primary outcome for the study related to a change in PAM-13 score between baseline and month 12. This was a highly activated population, and we saw no evidence of a clinically important difference in score or level between month 12 and month 0, or between 24 and month 0. One of the secondary outcomes was health-related quality of life. Quality of life measures were maintained between time points. Where problems were reported, pain and anxiety and depression were common, even in this very stable population. In the ProQual HIV questionnaire, participants scored highly in all domains apart from stigma, which varied by site. As one would expect, but reassuringly, HIV viral loads remained excellent in this medically stable population. 10 people had a viral load of more than 50 copies on 2 occasions, and none were lost to clinical follow-up. Self-reported adherence, as captured during using the MMASRI, showed a median VAS score of 100% at each time point. And there were no SAEs related to the pathway or platform, including no data breaches reported during the 3,891 years of patient follow-up or since. Face-to-face outpatient visits reduced by up to 30% in this group, with an associated reduction in cost for these individuals. Overall costs, as expected, were driven mainly by antiretrovirals. Again, with digital health, it is important to emphasize that this isn't and shouldn't be a cost-saving exercise, but much more for me around managing capacity in clinics. Reducing visits to clinic, noting that this was done pre-COVID, had an additional environmental benefit. Usability and patient experience scored well. I think, having shown you the data, it's always useful to talk through some case studies as well to give you an idea of what was happening on the ground. So firstly, just to talk briefly about our site in Zagreb. Zagreb, as you may know, is the one HIV centre for Croatia, led by Professor Josip Bekovac. He, his team and community colleagues at Lux Vitae describe well the benefits and the challenges of introducing a digital health pathway of care. They have been extremely positive about the process of using digital health frameworks to empower communities to participate in service redesign. As of now, they have around 40% of their HIV cohort using the platform, which has also allowed a more streamlined approach to checking results and improved governance, as well as empowering individuals by providing access to their results. And in Brighton, we started with an email service in 2008, which was the proof of concept for the Emerge project. We also now have 40% of our cohort using either Connect email or the Emerge app with an annual clinician visit to reduce visits to clinic. This has helped us to find capacity over the years, initially for our increasing cohort and now for those with more complex needs. Again, going back to my previous point, across all of our sites, the involvement of community and clinicians in co-designing the pathway and the support for this has been absolutely critical. The picture in the left-hand corner is my colleague Gemma, who's been keen to our success. We've gone on in Brighton in the last stages of the project to adapt the platform to support virtual pathways for PrEP. So what we did in Emerge was actually very simple, but it worked. I hope that in this example, I have shown you how important co-design of services in digital health, as in all services, is, and how this is the key to successfully resetting our services. Mhealth and telemedicine, particularly now, offer us great solutions as we move forward to reset our services, but it is essential that we keep care person-centred and that we offer digital health as a choice rather than a panacea. As we move forward, we need to think a lot more about digital divide, digital health literacy, ensuring that we don't increase inequalities, but rather we use our new digital age as an opportunity to improve access and to move forward. I'd like to just finish with this quote from the Director General of the WHO. We must make sure that innovation and technology helps to reduce the inequities in our world instead of becoming another reason people are left behind. And finally, just to acknowledge all of the partners in the Emerge project and to pay particular tribute to Martin Fisher, who some of you may have known, whose vision this project was. Thank you very much.